interest, including management of advanced chronic liver disease and liver failure, artificial support system, and portal hypertension. I know that hepatorenal syndrome is near and dear to his heart, and I'm looking forward to learning from him about it. Please help me welcome Dr. Frederick.
Good morning, everyone. Good to see you here. My name's Todd Frederick, hepatologist at CPMC. I did remember how to tie a tie. It's been a while since I had to tie a tie, so I was happy to put that together. I forgot how to shave, though. That was the other thing that came through the pandemic. All right, I have too many slides, and the counter's already counting down, and I'll try to leave time for questions at the end, so I might go a little quickly here. Let's see if I can get this going. So the outline, I want to review pathophysiology of portal hypertension, which I think sets the stage, and then specifically hepatorenal syndrome, but also the overview of acute kidney injury, updates and how to diagnose it, recognize it, and intervene. We'll go through some treatment options. There aren't a lot of treatment options for hepatorenal syndrome, but I'll show you some data. And then through in a few abstracts I found interesting from this past AASLD meeting. The stages of cirrhosis we think about, compensated versus decompensated. I still refer to child A for compensated, B and C for our decompensated patients, and thinking of them this way is, I think, helpful. The portal hypertension sets in early. It may be mild, defined by the hepatic vein pressure gradient less than 10. Clinically significant portal hypertension, CSPH, is defined as greater than or equal to 10 millimeters of mercury on that hepatic vein pressure gradient. And that's where we start to see complications from portal hypertension. Varices develop, and they can start bleeding above 12. Decompensation sets in, usually with progressive portal hypertension as part of that. And then we're going to talk a little bit more about the late decompensation phase, or perhaps the end stage liver disease. At a microscopic level, what's happening in the liver, I think, is interesting to keep in mind. On the left-hand side of the slide is a normal liver, normal sinusoids and endothelium. And you can see the fenestrae, which is unique to the sinusoids circulation within the liver, to allow proteins and other molecules to go in between the cells into the hepatocytes. And you can see the stellate cell in its non-activated state, storing vitamin A, and then activating into a myofibroblast as disease progresses, any chronic liver disease to the point of cirrhosis. You see the stellate cell now becoming contractile, having receptors to endothelin and other vasoconstrictors, and being less receptive to vasodilators or nitric oxide. And so a vasoconstriction happening within the microcirculation within the liver, in addition to the stellate cells depositing fibrosis, contributing to the cirrhotic pathophysiology and the fixed resistance with the fibrotic process. So there's a dynamic vasoconstrictor process and a fixed component. And so moving on from that, we've established portal hypertension, typically in the setting of cirrhosis, but it should be mentioned this can also happen in acute liver failure. Acute alcoholic hepatitis, I think, is a big example where some of those patients don't actually have cirrhosis, but they have tremendous portal hypertension. And what happens subsequent to that is a vasodilator response, mediators such as nitric oxide, carbon monoxide, endocannabinoids, and glucagon actually would be in this, are released and circulate in the primarily splanchnic circulation, vasodilating the splanchnic arterial bed, decreasing the vascular resistance, increasing the flow both through the arterial and then back through the venous system, which contributes to the portal hypertension. And this splanchnic arterial vasodilation, although the blood volume is the same, the body senses a reduced effective arterial volume, and that triggers all the compensatory mechanisms, which are helpful initially and then become harmful. These include the renin, angiotensin, aldosterone system, the sympathetic nervous system, and arginine vasopressin or antidiuretic hormones. So all of these are upregulated to pretty extreme degrees as portal hypertension progresses. And the renal artery is receptive to these mediators and starts to vasoconstrict. And eventually that vasoconstriction leads to a poor perfusion to the kidneys, decreased GFR. The kidney accommodates for this. It has an autoregulatory function, increases its prostaglandin production to continue to maintain a GFR as long as possible. In the cirrhotic population, that autoregulation seems to be impaired. But it also brings to mind the importance of why we recommend patients not to take NSAIDs, which would block this prostaglandin upregulation and contribute to worsening or higher risk for acute kidney injury. So the upregulation and the compensatory mechanisms are happening, but there's also most commonly a second hit when we see hepatorenal syndrome with either bacterial translocation or frank infection, or an epithelial injury, either to the liver or the gut or other, releasing these either pathogen-associated molecular patterns or damage-associated molecular patterns, triggering an immune response and cytokine release. IL-6, TNF, other endotoxins contribute to both the vasodilation problem that was set in motion from the portal hypertension, but also a direct effect on the kidney, reducing the GFR. So it's an inflammatory mixture superimposed on a predisposition with poor renal perfusion. And then perhaps the final hit would be an underlying cirrhotic cardiomyopathy, which I think is under-recognized in our patients. It's a high output heart failure. And as a second event, such as an infection or a bleeding event or other occurs, there's an expectation for compensatory upregulation of cardiac output, which is already perhaps maxed with this high output heart failure. And so that may also contribute to the pathophysiology of HRS. I also threw in there bile salts, I think also under-recognized in our markedly hyperbilirubinic patients. They get bile salt nephropathy, casts within the liver that can contribute to the overall AKI, and may be part of the reason we can't reverse this process in the majority of our patients. This is a slide just to the point of that hyperdynamic circulation in cirrhotics. You can see Child-Pugh A to B to C resting cardiac outputs that are all supranormal compared to the control. And it may result in a reduced compensation for stress. So these were studies putting patients with either controls or with or without ascites, and you can see the deltas there in heart rate, cardiac index, and ejection fraction were much lower for decompensated cirrhotics compared to controls. And another study looking at bicycle exercise demonstrates the same problem with inability to further compensate for higher cardiac output under physiologic stress. So think of your cirrhotic patient, particularly your decompensated cirrhotic patient, is already on a treadmill at baseline. Okay, so let's go back to acute kidney injury. And there have been some updates, both in general medicine, nephrology, but also adapted into the cirrhotic population. So on the left there, the traditional criteria, this was more for hepatorenal syndrome diagnosis, but let's think now just in terms of acute kidney injury. We had cutoffs that were required before we would label someone as having hepatorenal syndrome. And that was typically a creatinine of 1.5 or at least 50% over a baseline. And then it was usually 2.5 for type 1 hepatorenal syndrome. And these terms now, type 1 and type 2, are being phased out. And I'll go through that a little bit later in the talk. But now the concept of recognizing acute kidney injury as a delta creatinine from the patient's baseline. So 0.3 milligrams per deciliter is enough to now call acute kidney injury. That's within a 48-hour time frame, or an increase from at least 50% from baseline that is presumed to have occurred acutely within the last week. And you can use a baseline. Let's say you have a lab from 3 months ago, that could serve as a baseline if it's presumed that there was an event triggering what's happening in front of you, this AKI. And these thresholds are adopted from the nephrology literature. This wasn't unique to liver disease. Staging is also updated. So stage 1 would be a minor increase in the serum creatinine 0.3 to a 1.5 to 2-fold increase from that patient's baseline. If it's a 2 to 3-fold increase, now we're talking stage 2, and then stage 3 would be a 3-fold or an absolute above 4, or someone needing dialysis. And then a text there, stage 1A and 1B have absolute creatinine cutoffs of 1.5. And part of that is a prognostic tool. So part of the reason to have new cutoffs or new diagnostics for AKI and cirrhosis would come from this study showing on average, you can diagnose patients, at least with HRS, this was for an HRS study, you can diagnose patients earlier than having to wait for these doublings of creatinine to these thresholds that were higher. So in this study, that the diagnosis could be made in a retrospective sense 4 days earlier and at a 1 milligram per deciliter lower creatinine. This was a treatment trial for HRS. And so that may have big implications for treating patients and actually being able to reverse hepatorenal syndrome, which we know we do better when the creatinine is lower. Back to the cutoffs for creatinine, this is 2 different studies, actually hospitalized patients with cirrhosis and AKI, and you can see the mortality implications. On the left, the mortality increases with the increasing stage of AKI, and the subtext there between stage 1A, where the mortality was not different from baseline, versus 1B, which was that cutoff creatinine 1.5. So once you hit a creatinine 1.5, that number still carries importance more for prognosis, not so much for diagnosis. And then stage 2 and 3 AKIs, you can see the mortality increased considerably. The epidemiology of AKI and cirrhosis, this is a review of the national inpatient sample from a little over a decade. The prevalence seemed to be increasing, doubling actually, from 15% of hospitalized cirrhotic patients having AKI to now nearly 30% having AKI. These lead to longer stays, higher cost, and higher mortality. The only silver lining here was that overall mortality in cirrhotic patients with AKI during the course of this assessment was declining. So perhaps we are doing something right to help our patients with cirrhosis and AKI, but the problem is, as a prevalence, is overall getting worse. So we're still using serum creatinine for all these diagnoses. AKI is based on a creatinine. We have it as part of our basic metabolic panel, but it's a limited tool to estimate GFR, I think across the board, but also particularly in cirrhotic patients. As a muscle breakdown product, a lot of our patients have less muscle, or sarcopenic cirrhotic patients in particular. And so this is a slide showing you the differences between a normal subject and their serum creatinine as it would correlate to their GFR, and a cirrhotic population, presumably with sarcopenia. And you can see the same serum creatinine, let's say we picked 1.5 on that graph, would lead to a markedly different GFR in many of our cirrhotic patients. Now, this isn't true to everybody. If you have a larger, higher muscle mass patient with cirrhosis, that creatinine may reflect a more normal GFR. But I think we just need to have a higher degree of sensitivity to what an elevated creatinine means in this population with rapidly reducing GFRs. So other biomarkers, Cystatin C is studied a lot. It is available through commercial labs. Some centers are using this more routinely now. It's a protein continuously produced by all nucleated cells, so not a muscle breakdown product. And it has advantages by not being influenced by age, gender, muscle mass, inflammation, malignancy, or hyperbilirubinemia, which was an older problem with the creatinine. We had to get enzymatic creatinines because patients with high bilirubins would have falsely low serum creatinines because of error in the test and picking up creatinine. So Cystatin C may be a future tool for us to better estimate GFR across the spectrum of different patients. All right, so AKI and cirrhosis, I think we naturally go to HRS as the first and most likely diagnosis, but it's just one of the diagnoses and actually not the most common that we see. So it's important to keep a broader differential, thinking about the three different groups overall: pre-renal, intrarenal, and post-renal. Within pre-renal would be the hypovolemic group, dehydrated patients on diuretics perhaps, or with bleeding and hypoperfused, diarrhea from lactulose or other, or aggressive paracenteses. That's the most common cause of AKI in our population. Hepatorenal syndrome is included in that pre-renal group by functional definition. And then there are intrinsic renal diseases, ATN or acute tubular necrosis being most common, but you may see a GN, IgA nephropathy, perhaps interstitial nephritis. So looking at urine and the microscopic urine, looking for casts and cells as part of this process. And then not missing obstructive uropathy, a big prostate, for instance, or a mass would be important, but those are unusual. Prevalence, this is just to show, this was a pooled study looking at multiple smaller studies of hospitalized cirrhotics. Overall, 19% of them had AKI either at admission or during the hospital stay. The majority of those were in that pre-renal category, which again includes the volume responsive group, which is the most common, hypovolemic, infected, other, or the not volume responsive, which is how we're going to diagnose HRS. And that was a smaller proportion. And you can see also a third of these patients had intrarenal causes. So again, the differential for AKI and cirrhosis is important to keep a perspective on that. The etiology of the AKI does have implications not only for how we treat it, certainly, but how patients do. And the pre-renal azotemic patients or volume responsive do better than patients with either HRS or ATN. You can see here in this study at a 90-day timeline. All right, so now we'll focus more on HRS and set the stage for how to think about who likely or more likely has HRS. We have common precipitating factors. We don't always find a precipitating factor, but if you have one of these in this background of a patient with decompensated cirrhosis, almost always with ascites or hydrothorax, almost always with hyponatremia. So think in that mind frame in terms of diagnosing HRS. And it remains a diagnosis of exclusion, having ruled out intrarenal pathology post-renal, and ATN being probably the hardest one to distinguish it from. The patient has to have a diagnosis of AKI. So now you can diagnose HRS with a 0.3 milligram per deciliter increase of creatinine. The type 1 and type 2 terminology is being, again, moved away from. These patients, you can't diagnose HRS on admission to the hospital. You can presume it perhaps, and suspect it, but you have to have patients off diuretics, fluid challenged with albumin plus or minus crystalloids if they're particularly dehydrated for at least 2 days. And there are recommendations for dosing of albumin. Now you have to make sure these patients are not in ongoing shock. Many of them have had shock and have recovered, or they had a bacterial infection that they're recovering from. Take a history for nephrotoxic drugs, particularly NSAIDs, and look at the kidneys, look at ultrasounds and urinalyses. So as you're waiting, these 48 hours seem like an eternity in the hospital. You're giving albumin and other fluids. You're trying to figure out if your patient's volume responsive or not. I like some of the studies that are coming out on biomarkers, renal biomarkers that may give us more clues up front and during the course of the AKI to distinguish between some of these entities on the differential diagnosis. So I underlined NGAL, neutrophil gelatinase associated lipocalin. NGAL has been looked at for a while now, and it's particularly helpful. It looks in distinguishing pre-renal azotemia. There was a chronic kidney disease population, HRS, and then ATN. And think of it as a renal tubular injury marker. So it's increased. This is a urinary test, at least in this study. They also can measure it through the serum. But you see an increase in ATN with tubular necrosis. But HRS isn't as low as the pre-renal azotemic. So perhaps there's a continuum and actually some injury to tubules that's happening within the HRS physiology. The other point to take away with NGAL is it may have an acute phase reactant component and increases with infection. So in this study, patients with HRS with an infection had a higher NGAL, closer to those with ATN. So that might be harder to distinguish. There was a nice abstract and oral presentation at the liver meeting this year, looking at these biomarkers for prognostic purposes, but also responsiveness to vasoconstrictor therapy. And they found both cystatin C and urinary NGAL were predictive to help etiology of AKI, but also response to vasoconstrictors for those with HRS. So I'm interested in seeing more of this and to help us figure out who needs what treatment and perhaps getting treatments to patients sooner. And they also found mortality prediction with these biomarkers. All right, so I'm going to keep moving as this clock keeps counting down. So older terminology, HRS1, you don't necessarily need to diagnose it as 1 or 2. Think of HRS physiology. And now we talk about HRS AKI or HRS non-AKI. So if it doesn't meet the AKI criteria, but there's renal impairment and they have HRS physiology, these patients may have HRS acute kidney disease or HRS chronic kidney disease, and the timeline's 3 months or less or greater than 3 months. So the old HRS2 may now be discussed as HRS CKD. This is still newly introduced, and I think there's still people need to figure out if we're going to accept these terms broadly. But the HRS AKI, I think, is solid now, and you'll hear that more and more. The ASLD came out with new guidance. This was just a couple of months ago. Scott Biggins, Ray Kim was part of this as well. And there's great information on ascites, SBP, and HRS, and I'll walk you through their approach that was recommended for AKI. So again, this 0.3 milligram per deciliter increase should call your attention. You're now looking at someone with AKI. You're looking at their urine, clinical history and exposures, medications. You're looking at other biomarkers. And if you can make a diagnosis based on that up front, you know the patient has ATN or a UTI or urinary tract obstruction, then you treat that accordingly. But for the most patients, you won't have that diagnosis up front. And then you stage it. If it's a mild AKI stage 1, less than a doubling, then you go through further risk factor management, adjusting or withdrawing diuretics, making sure they're not on any nephrotoxic drugs, treating infections, repleting volume. If they're more severe, they're at stage 2 or 3, they've doubled their creatinine, then you go straight to albumin resuscitation, plus or minus other crystalloids if they're particularly volume depleted, which I think we under-recognize. I think a lot of our patients are more volume depleted than we sense, even with ascites. And if that helps, if they resolve, then you monitor. If it's not working, then you have an AKI that's not volume responsive. You've hopefully ruled out ATN or others, and now you have a diagnosis of HRS. So what do we do now? Vasoconstrictor therapy is the mainstay, and I'll go through that next. So treatment of AKI-HRS is albumin up front for both the diagnostic process for 48 hours and then during treatment, and then adding vasoconstrictors. Liver transplant should be considered along this timeline. These are sick patients, typically have very high MELDs, have very high mortality rates. So as we're trying to treat the AKI, we should be thinking, are these transplant candidates? And if so, get them evaluated. And then renal replacement therapy is an option for maintaining patients, at least to try to serve the function of the kidney, but it doesn't restore renal function, of course. So thinking about how these vasoconstrictors work, and I apologize for the slide, this really reflects more Terlipressin as a vasoconstrictor, as I thought about it more, as opposed to norepinephrine or midodrine. But those are our 3 options. In the US, midodrine is widely used as a vasoconstrictor. It's a peripherally acting alpha agonist, coupled usually with octreotide, with the idea that the octreotide blocks the endogenous vasodilators that are being produced. Norepinephrine is also available as an alpha and beta agonist. And then terlipressin is still an investigational agent, which is a vasopressin 1 and less so vasopressin 2 receptor agonist. But the idea with terlipressin would be to reduce the splanchnic vasodilation, create more vasoconstriction, reduce the portal pressure by the venous return through the portal circulation, restoring the effective arterial volume, and then really down-regulating those compensatory mechanisms that were set in motion, the renin, angiotensin, aldosterone, the sympathetic nervous system. So the effect takes days. Usually it's not overnight. It's at least 2, 3, 4 days for these down-regulation effects to happen. And then that should allow improved perfusion to the kidney, relaxed vasoconstriction of that renal artery, and improved GFR and HRS reversal. So data on HRS therapy, there are probably more meta-analyses out there for HRS than there are actually studies on HRS, but I'll walk you through a few of these. So this was a meta-analysis looking at these vasoconstrictors compared to placebo, and I highlighted in bold. They looked at both short-term mortality and then reversal of HRS. And you can see in the short-term mortality, there's never been studies showing benefit, except with one, actually, I'll show you, that was published after this meta-analysis. But for the most part, we're talking about ability to reverse HRS. Midodrine and octreotide, unfortunately, despite wide use in the US, has not been shown to convincingly reverse HRS, and the quality of evidence is low. However, norepinephrine and terlipressin both have data, although the quality is of question, but they have high odds ratios for reversing HRS. So then comparing head to head, at least in a meta-analysis form, norepinephrine has more efficacy compared to midodrine and octreotide, as does terlipressin. You can see those odds ratios, but with only low to moderate quality data. And then there was one study comparing norepinephrine directly to terlipressin, which was not found to be different in terms of reversal. I'm going to move through that. Just another meta-analysis. And we'll look at a few of these studies pulled from actually subsequent to the publication of these meta-analyses. This was terlipressin versus midodrine and octreotide head-to-head study, 49 patients using older terminology. Most had HRS1, some had HRS2, but had to have a creatinine of 2.5 at the time of enrollment. So sick patients with severely reduced GFRs. The terlipressin was given as a continuous infusion in this study, midodrine and octreotide per standard dosing, both groups given albumin. And you can see the complete response shown in this table was markedly higher for the terlipressin group versus midodrine and octreotide. It really leads you to wonder what we're doing with midodrine and octreotide if it's a 4.8% complete response. They did have around a 29% partial response. So I think we see some improvements in GFR with our current de facto standard of care, but certainly not much in terms of complete response. One of the takeaways from the study was the delta mean arterial pressure, which was significantly higher with terlipressin, supporting its mechanism of action and improving perfusion, improving GFR. I'm going to keep moving because that counter is clicking through. So these were some other studies. This is norepinephrine versus terlipressin. This was a different subset of patients. These all had sepsis and acute on chronic liver failure. This was a large study, 60 patients in each arm. They all had at least stage 2 or higher AKI by the newer criteria. Terlipressin, again, by continuous infusion, as opposed to intermittent bolus, compared to norepinephrine, both of which were titrated to effect. And you can see in this study in particular, terlipressin came out ahead for HRS reversal, more than double that of norepinephrine. And they actually showed, this is the only study I've seen that showed a mortality benefit associated with this reversal of HRS for the terlipressin group compared to norepinephrine. I should mention there on that slide also that the side effect profile for terlipressin was higher there were more drug-related adverse events in the terlipressin group compared to norepinephrine, and that was statistically significant. Terlipressin, I'll go through. I apologize, I'm running out of time already. It's a synthetic prodrug of vasopressin. So it's a prodrug of lysine vasopressin as opposed to what we have as arginine vasopressin. So this is the porcine version of vasopressin. It's a prodrug. It's felt to have benefits for V1 receptors, agonism more so for V1 as opposed to V2. And V1 receptors are in smooth muscle cells, so vascular smooth muscle, but also GI smooth muscle, lung smooth muscle. So some off-target effects may be GI related with abdominal pain or even ischemia, and then lung related perhaps with bronchoconstriction. There is some V2 receptor activity, so we have to keep that in mind. It, as a antidiuretic hormone, it may increase free water absorption, leading to volume overload or hyponatremia. And I think, gosh, am I out of time? Yes. Yeah, I think I will stop there and take any questions.
Thank you so much, Dr.
Sure.
Frederick. Question from the virtual attendees. A lot of patients that we're describing are already on octreotide. Does that alone help the management of HRS?
Not data supported. There's a theoretical benefit with blocking the endogenous vasodilators. That's how we think it treats variceal bleeding, reducing portal hypertension. But the data to support octreotide as monotherapy is even more scant than that combined with midodrine.
Thanks, Todd, for a great talk on a challenging topic. I'm curious about some of the diagnostic biomarkers that you mentioned. How are you using those in clinical practice? And are there any data on using those to sort of risk stratify who may or may not respond to certain types of therapies for HRS? Yeah,
so I am not using them outside of research, Cystatin C as part of a research trial that we have ongoing. I've talked to colleagues who do have access to Cystatin C in their centers. So you may have access to that where you work. The NGAL, as far as I know, is purely research still, but seems to me the most promising. And I'm interested to see more. That abstract I mentioned from the liver meeting in November did show predictors for response with NGAL in terms of vasoconstrictors for HRS. So those who had higher NGAL levels were less likely to respond to terlipressin in this study. And thinking of it, the higher NGAL was seen more often with ATN, and I mentioned that continuum. So I think we try to put patients in buckets. This one has ATN, this one has HRS, but the reality is there's probably more overlap. And I think a patient with more urinary or renal tubular injury markers in their urine, it makes sense to me that that patient may not respond as well to a vasoconstrictor.
Thank you.
Last question in the interest of time from the virtual audience. Can you comment on the beta blockers in the setting of acute kidney injury?
Great question. I neglected to mention. So in the setting of AKI, part of risk management that the ASLD guidance came up with is to at least temporarily hold beta blockers. It's a very good point. So if your patient was on that for prophylaxis against variceal bleeding, it should be interrupted. It potentially can be reintroduced once the patient's stabilized, but it's a hard medication to use in these patients with low mean arterial pressures and reduced GFR, particularly with the refractory ascites that we often see. All right, thank you.